I'm Mike Bouvet, and I'll be talking about emerging clinical trials on tumor detection using ICG imaging and endocrine surgery. And I just want to thank Raul and Fernando and everybody for organizing such a wonderful congress. You can't beat the views. It's just amazing. And the talks have been great. So my topics this morning are going to be thyroid surgery, parathyroid surgery, adrenal surgery, and pancreatic neuroendocrine tumor surgery.
Fluorescence guided surgery of the esophagus. What have we learned in 2024? My name is Ori Weissel.
And some future directions as well. So in terms of thyroid surgery, how do we use ICG for that? It's really all about preventing complications. And really one of the main complications for thyroidectomy is hypoparathyroidism. And you can see on this slide how small that little parathyroid is. The normal parathyroids are only the size of a grain of rice. And if you have hypoparathyroidism, you're going to have numbness and tingling in the hands and fingers, perioral paresthesias, cramping, irritability, Schwarzschild-Trousseau signs. We have a number of devices now that can detect the autofluorescence of parathyroid glands. There's two FDA-approved devices, the FluoBeam and the PTI. We've been using the PTI at our hospital in San Diego. And ICG can be used to tell whether or not that parathyroid that you've identified is well perfused. And here's a well-perfused parathyroid. You can see the nice green color on the color overlay, and there's the recurrent laryngeal nerve right next to it. So you know that patient has at least one well-perfused parathyroid. I think that one of the landmark clinical trials came out of Geneva, Switzerland with Frederick Tripone and Dr. Fortuny, and they did a randomized clinical trial of intraoperative parathyroid gland angiography using ICG. And what they found was that if you have at least one parathyroid that is nice and green with the ICG, the patient won't get hypoparathyroidism. And in fact, once they started using ICG routinely during their thyroidectomies, their rate of hypoparathyroidism postoperatively went way down. And you can see on that graphic that the rates came down to less than 4%. We also use ICG. I've used it a lot for parathyroid surgery, where we take out the parathyroid for hyperparathyroidism. And as you may recall, the clinical presentation, patients can be asymptomatic, where they just have a calcium that is elevated on a chem panel that they got, or they can have symptoms like kidney stones, even gallstones, painful bones from osteoporosis, groans, which is the ulcer, and pancreatitis, moans, and psychic overtones. And the typical parathyroid adenoma is depicted here. It's about 2 centimeters, just sheets of cells on the frozen section. We first used ICG about 10 years ago. We wrote it up and published a video in Video Endocrinology of our case that we did. So it's been around for a while. When I first started, I was using the pinpoint, which was very awkward in the neck, and it's really not built for neck surgery. It's more for abdominal surgery. So later on, Stryker came up with the SpyFi device, the portable handheld imaging device, and some pictures of that. And so we started routinely using that on parathyroid adenoma surgery, and you can see a little video from the operating room of how you can set up the SpyFi using a retractor that goes onto the side of the table. So here's just one example of a parathyroidectomy with SpyFi. This lady had hyperparathyroidism, had previous failed parathyroid surgery, had limited mobility in her neck with a lot of hardware. Nobody wanted to touch her. We did a good CAT scan and saw a parathyroid adenoma just below the sternal notch. And then we brought her to the OR, and I found what I thought was the parathyroid, and then gave ICG. This is within about 20 seconds, you can see that parathyroid takes up the ICG, and you can use either the black and white mode, where you can see the blood vessel supplying that parathyroid adenoma, or you can do a color overlay mode. And we wrote up this experience and published it in the American Journal of Surgery a couple years ago. We had 66 patients, Average age was 64. You can see the statistics there. And the protocol was we'd obtain a PTH level prior to induction of anesthesia. We'd identify a candidate gland. We'd give just 1 cc of ICG because the SPY-FI was very sensitive. And then we were interested in how long it would take to light up the parathyroid. So we looked at the first time of initial fluorescence and then peak fluorescence. And it really was fast. So the initial time to fluorescence was 26 seconds, and the median time to maximum fluorescence was 38 seconds, and it really only added a couple minutes onto the case. And the other thing with the SPY-FI is you can do some quantitation. So this is an example of the QP function on the SPY-FI, where you can set the parathyroid to 100%, and then you can scan around and you see how that drops off in different areas. And so we've been collecting prospective data at UCSD, and hopefully we'll be publishing that data pretty soon about what do you expect when you look at the other organs in the neck, like the thyroid or the adjacent fat or the carotid. So there are some limitations, and if you can get a false negative if the blood supply to the parathyroid is compromised, and you can get high background in a lot of cases, and that's one limitation. We did write up a paper with a series of Delphi studies that Fernando was the first author, and this came out in Surgery in 2022, looking at the results of fluorescence imaging in parathyroid surgery. And the conclusions were that autofluorescence is better than ICG for localizing parathyroid glands. ICG is better than autofluorescence for assessing perfusion, and that ICG can aid in multi-gland disease, redo parathyroid surgery, and facilitating parathyroid gland autotransplantation. I also want to move on to adrenal surgery because I do that in my practice as well. And you have the anatomy is quite different between the right and the left adrenal glands. The right being very close to the vena cava, and the left is a little farther away. So here's an example of a laparoscopic left adrenalectomy using ICG. This lady had Cushing's disease. You can see the stria on her abdomen there. And she had a tumor in her left adrenal, which was about 4 or 5 centimeters, that was making too much cortisol. And so we did this with the laparoscopically on her side. And you can see with giving the ICG, you can immediately see the blood supply to the adrenal light up. And then a few seconds later, you see the adrenal vein there. And then, black and white mode is helpful. The adrenal gland itself also takes up ICG, and so does the tumor. And so here you can see the tumor here, and actually the normal adrenal took up even more ICG. So we're just going to clip off that left adrenal vein, which drains into the left renal vein. This is a relatively straightforward case here where we identify the vein. The other thing that I found it helpful for, you can see the kidney in the background. So on some more difficult cases, it's kind of behind there, where you're worried about the blood supply to the kidney, say if there was a blood supply to the adrenal, the tumor was very close to the renal artery, you can make sure that your kidney is well perfused. And then once you get that adrenal vein ligated and divided, you can really do fluorescence-guided surgery, and you can take out the whole tumor as well as the adrenal gland using that color overlay mode. And this is just a little example of how true fluorescence-guided surgery, where you kind of just march along and you make sure you get the whole thing out. The left side, or the right side's a little trickier. This patient was a 64-year-old female hospitalized for shortness of breath, and the chest CT showed this incidental lesion there in the adrenal gland. And here we have the vena cava and the adrenal vein exposed, and we give ICG just to confirm the anatomy. And if you look at the black and white mode, it's really spectacular about how you can see how much blood flow is going through the vena cava there. So you can see that. Maybe you can't see it too well on this, but you can see the correlation between the perfusion and the ICG. And then we'll go ahead and divide that adrenal vein, which you can confirm right there using ICG. So we routinely use it on all our adrenalectomies. We wrote up our experience in the Journal of Surgical Oncology. I also want to just show another video on pancreatic surgery. This is a lady with insulinoma, which is a tumor that makes too much insulin. We thought we found it, localized it to the tail of the pancreas, and she was quite obese. BMI was 46. She was unable to lose weight because whenever she tried to lose weight, she would get hypoglycemic and get all the symptoms of hypoglycemia. So a little short video of that case that we did with the Stryker laparoscope. I don't know if this was the 1688 or the 1788, but it had all the capabilities. And to get back to the pancreas, we had to mobilize the stomach and get into the lesser sac, of course. We have the patient sort of with the head up, and we use a little padded retractor to retract the stomach so we can see the retroperitoneum and the pancreas. And here we're sort of dissecting, it's hard to find the tumor in this fat because her BMI was 46. But there we found the splenic artery and a little more dissection. We were looking in the area where we thought the tumor might be, so we carefully incised the peritoneum overlying the tail of the pancreas. And this is really spectacular. So you can kind of see and we think we found the tumor right here. We've given some ICG, and then the tumor is going to start lighting up right there. So the color overlay mode, you can clearly see that little neuroendocrine tumor. And that's one of the things about the endocrine glands. They have such a rich blood supply because they have to make hormones that are important for all sorts of things. And so here we are taking the tumor out, and then it just glows in the dark there with the ICG. So she did quite well, and her pathology just showed a benign adenoma. So the last couple of minutes, I'll just show what I think the future directions are. I think there is going to be some pattern recognition, probably AI software for ICG fluorescence that could help. There's also going to be more tumor-specific probes for parathyroid and thyroid surgery. There's more clinical trials on the way for color-coded endocrine surgery. I'm not going to talk about imaging the nerve. That'll come up later, but you can image the nerve also with fluorescence techniques or autofluorescence. I was lucky and I got an R01 grant with a researcher at Harvard named Hak-Soo Choi, who came up with two different dyes. One was specific for thyroid and the other was specific for parathyroid. So we have a mouse model of MEN1 where the mice develop pancreatic tumors and parathyroid adenomas, and we're going to try these dyes in that model and also a pig model of parathyroid. Also, these are just some pictures. The parathyroids in a pig are at the top of the thymus, and they only have two parathyroids, so way up here. And they're still kind of tricky to find, but we were able to find them, and so we're looking forward to using the dyes to see if it'll make it easier. Next week, actually, I'm flying back to Tampa to the SSO meeting, and we're going to present our data using a humanized anti-CEA in a mouse model of medullary thyroid cancer. And you can see how nice that dye lit up the medullary thyroid cancer in these mice. And we also are going to present some data at the American Association of Endocrine Surgeons meeting in Milwaukee in May on a novel spray that will detect lower pHs that are in tumors. And this is a mouse model of papillary thyroid cancer. And you just open up the neck after you've implanted the tumors in the thyroid, and you spray the pH probe on it, and it'll light up. Yeah. And so this is also from Hak-Soo Choi, my collaborator at Boston, and we did the studies in San Diego in our mouse model in my lab. So that's it, and we'll finish on time. If you come out to San Diego, come by and we'll show you the UCSD Center for Future of Surgery where a lot of these studies were done. Thank you.